Thank you very much for having me speak with you this morning, or this evening as it is in your neck of the woods. So today we're just going to be talking about a additional treatment that you can use as part of the EthOss protocol, which we've been doing for a little bit of time, and it just extends what EthOss can do a little bit. My background is I'm a general dentist with an interest in dental implants. I've been doing implants since 2002. I graduated from the University of Birmingham in the UK, and I moved to Spain with my wife in about 2007, and we bought a practice on the south of Spain. And we lived in a place called Marbella, which is rather nice and sunny, but kind of like your weather. But kind of missed the weather back in the UK and the teeth of the UK, so I sort of moved back to Yorkshire, and I live in Sheffield now, and we have a specialist referral practice that is focused on endodontics, periodontics and implant dentistry, and sort of restorative work just south of Sheffield. So EthOss, it's a bit of a revolution, and I'd like to just take you through a little bit of my journey with it, and the technique that we're going to discuss today. So the title of the talk is Tenting Sutures, and so it's an alternative to more invasive treatment. Can we make it less invasive? Can we extend the use of particulates into areas where maybe we would have struggled before? So Leonardo da Vinci, one of my favorite quotes is simplicity is the ultimate sophistication. So the more that we can take out of stuff, the less steps that we can do, and the less we have to push things from a surgical perspective, the better, in my opinion. So the aims and objectives. Just going to discuss a little bit my experiences with synthetics and the potential refinements to the protocol that I'm sure you've seen from Peter Fairbairn. Tenting, where's it helpful, and some materials, methods and examples. So with my grafting, the question I always ask myself is, what am I trying to achieve? You know, you see a lot of very fantastic carpentry going on Instagram and things, and Facebook in the modern generation. You think, well, you know, that's all great, but you can tend to look at a lot of these things, and as you use EthOss more, you'll look at a lot of these cases and think, well, I can probably do that with a lot less morbidity and a lot less problems potentially with these synthetic materials. So the main thing that we're looking at, obviously, is patient outcome. You know, they're not bothered about what you're using. They want a tooth, and they want it to look like a tooth. And not only do they want that, they want the pink to come down to where the tooth is, and that's the aesthetic zone, really. The zone between the tooth and the pink. White aesthetics is very easy to get. All you need is a very good technician. The pink aesthetic is really the thing that we focus on, and that's where extra techniques like this little thing start coming in sites that are a little bit more compromised. So we want to minimize trauma. So ideally, I'd like a single surgical site, minimize the number of surgical procedures, cut down the amount of swelling and pain. And I don't know if you lot have been using EthOss that long, but you may find that compared to old protocols using bovine products and membranes, you might find that the reduction in pain and swelling is quite significant. and also the gain in soft tissue as well. This is an area that we've been looking at for quite some time, and it does seem anecdotally that we're getting a lot more soft tissue than you would expect by using these materials. So what are the alternatives to gaining volume? You've got titanium mesh, which need removal, and I must admit that I've had some disasters, shall we say, with tie-based membranes. I've had some amazing results as well, but you know, it can be difficult and messy to do it. iGen, I've not used it, but looks quite interesting. We've got the bone ring and Kuro plates, which is kind of still the gold standard if you've got a very big defect, and if you've got something that needs a Kuro plate, then it's beyond the scope of what you can really do with a pure particulate on its own. And then CAD/CAM blocks, they're coming on, but I'm still, I think we're probably going to stop talking about those in the future. Minimizing of time, you know, this is kind of what the normal sequence would be. You'd have an extraction, and then you'd wait 3 months. That's how I was taught. Site assessment, and then you could graft it, and then 3 to 9 months later it was implant placement, and then 3 months later restorative phase, possibly some connective tissue work somewhere in between. What we want to do is try and challenge this paradigm and see if we can't just condense some of these steps with the protocol. So can we take the extraction down to 1 month using the Falev protocol, and take advantage of the site healing and the regional acceleratory phenomenon that's going on within the site in order to turbo boost our implant placement and graft healing, upregulating bone growth at that 1 month stage. Get rid of that, because instead of grafting a load of material in and then drilling it out 6 months later or 9 months later, let's use the implant as a graft material, because the implant itself, titanium, is an osteoinductive graft material. So let's put that in at the same time and then restore at 3 months. I'm sure you've seen quite a few cases on EthOss case studies where on Facebook, and if you're not a member of EthOss case studies, it's a Facebook group that obviously does what it says on the tin, and you can join, and you just apply to join, and then there's a whole load of cases, and if you're ever unsure about a case or an x-ray or anything like that, put it up and the collective will give you some advice on what to do with that case. It's a very useful resource. But you'll see a lot of cases where Peter and some of myself and Minas and others will have done this sort of thing with defects that you may have considered in past years to be quite significant and needing multiple stage therapy. And you can actually deal with these just with a pure particulate following this protocol, which is quite useful. So cost as well. If you can minimize the amount that these things cost, minimize chair time, it gives you a competitive advantage, because you're not hurting the patient and you're not causing them too much pain in the wallet. Or you can charge what you would have charged, but obviously your profit goes up massively because of the lack of extra steps. You know, even simple things like if you're doing multiple stage procedures, you're going to have to take more sutures out. You're going to have more review appointments in between times. So what it does is it frees up chair time for you to do other productive activities as well. So it's a double whammy, and less stock as well. So there's a high margin of safety as well with these materials, especially when you start considering the sinus compared to placing things that have got hydroxyapatite, large crystalline structures in the sinus. This, if you get a perforation, it's not a problem. So I'm not going to talk about that today, but the margin of safety, and if you get a wound dehiscence, for example, it's not a big problem. Whereas with other materials and other membranes particularly, it can be a very big problem if you get a wound dehiscence. So which grafts do I prefer? You've got the two different types, as you know, particulate and block grafts. My preference is particulate for many reasons. You get much better neoangiogenesis with particulates. The ideal particulate is osteoinductive, osteoconductive, biocompatible. It's got an appropriate resorption time in relation to bone formation. So you don't want it to stick around forever, but you want it to stick around for long enough that the scaffold is stable. And maintenance of the graft volume and stability follows on from that. And satisfactory mechanical properties when you're actually placing it. And these are the important ones as well. No disease transmission. So if you've got something from an animal or human origin, however minuscule it is and however well treated that product is, there's always more of a risk of something sticking about within the graft material compared to something that is produced in a factory and sintered at, you know, over 1,000 degrees. And this is totally replaced by natural host bone as well. That's what you want. You want your graft to be there for an appropriate amount of time, and then you want it to be gone. And the great thing about that is twofold. It tells you that you've got a good result, because if your tissue stays stable and everything looks good, and it's 2 years down the line, you know that it's good. But also, importantly, you know when it's not good, and you know fairly quickly. You can actually be falsely lulled into a false sense of security if you're using a lot of hydroxyapatite-based products, where you actually think you've got a good result, and it looks great on an X-ray, but what you've got is a little bit compromised, and then you get these sort of mid failures at, say, 2 or 3 years where it's not really ever been quite right. And so if it's going to fail, it fails within the timeline of the treatment, and you can accommodate that. Whereas you can be lulled into a false sense of security with other grafts. And I think there's a whole extra subject on that. There's a few interesting papers on late failures with bovine-based grafting materials, which are starting to appear in the literature. So those are what we want. And then osteoinductive biomaterials. So you've got polymers, metals, titanium, importantly, is osteoinductive. So why not use titanium as part of your graft material? Because it stabilizes it too. Ceramics, which is what we're kind of talking about. And then in the middle, we've got synthetic sintered calcium phosphates, which is beta TCP, hydroxyapatite, and then bioglass and others, Pyrex as well, have been shown. And there are some interesting fibers as well that are coming out, which are coming out of the university, which are osteoinductive as well, which are quite interesting. Biocompatible goes without saying, and then we'll get rid of. So then you've got the different types: autologous, xenograft, allograft, and so we want to have at the bottom, xenograft and synthetic materials, which is the main things that we use in dentistry these days. Which one? I tend to go towards the synthetic materials. BMPs and PRF, they both have well-established data on them, and we can't really use bone morphogenic proteins in the UK, and there is an increased cancer risk with them as well, and they're very expensive and hard to obtain. So it's one of those things that makes me nervous. I certainly would never use them. PRF and PRP, there's a lot of data coming out saying that they're very useful for early healing, but you've got expensive equipment, you've got to spin blood off, and in many ways, these are an answer to a question that is based around having big grafts and membranes, and so decreasing the inevitable inflammation that you get from having resorbable membranes underneath to hold your graft in. They become obsolete when you start taking membranes away and start reducing the amount of initial swelling in the wound. So again, useful, but I don't use them myself. So I'll get rid of that. So which would you prefer? And if you've got patients who are increasingly worried about animal welfare, and particularly some religious and vegans, it's much better to give them a synthetic thing. And I tend to think along the lines of when I first started, we were all on rubber, natural latex rubber gloves, and you'd have to ask every patient whether they were allergic to latex. And now we all use nitrile gloves all the time, and so we don't have to ask the question anymore. It's just we use nitrile gloves and we don't worry about it. And I think we're probably going to move in that direction in the implant and grafting mentality as well. So if it's just made in a factory, we don't have any of these ethical considerations. So this is all a little bit about osteoinductive ceramics and synthetic grafting. I'll skip this actually, but basically it's long-term data is there. We've been using these materials in bone surgery for over a century now, and they're very, very well established. So this is one of the first cases I did with synthetics and the 1 month technique back in 2007, and we had a normal extraction, a small defect, and a month later we go in and place a dental implant. The thing that you note about doing it a month later is that you've still got the sharp edges from the extraction sockets, which hasn't flattened off. And what this does is it acts like a cup to hold the graft material. This is the rationale behind doing it at 1 month, is that you've still got quite a lot of the bony anatomy that will help stabilize the graft. So it's not resorbed yet. This is an old material called EthOss Vital, but it's quite similar to EthOss. And so it acts like a shelf to hold the stability of the bone. Again, back we were using silk in those days. And yes, that is what it looks like afterwards. You can see the eminence here, the gingival cuff. It's maintained very nicely. I couldn't actually remove the mini implant, so I ended up just leaving it as part of the bridge. So the question is, what do we do if we need this site here? Because there is no anatomy there. Again, going back to the turnover, what do we want in a site like that? We want something that is going to stick around for long enough that it's useful, but short enough that it doesn't stay and disrupt the actual bone growth, and so that you don't actually get proper osteoid and bone formation. Obviously, with more volume and more stability, you can grow more bone, figuratively speaking. But the question is it actually bone? And that's one of the things that we need to ask ourselves. So the other factors that you need to consider as well, apart from the material in the site like that, is the tissue stable, and do you have muscle pulls in the area? Certainly down in the lower premolar region, you've got frenal attachments and things, and so that can be difficult as well. So the question is what to do when there's no retention and you've got a thin site that's vertical. So we can use horizontal bone augmentation, and this is quite an interesting thing from, I think it was Carl Misch, and effectively this is the old kind of protocol that you'd follow. So if you didn't want much gain, you could do GBR, which is what we're talking about. Moderate gain, again GBR with a bit of ridge expansion maybe, and then maximal gain, it was always a block graft, titanium meshes and things like that. The question is, can we change that? Because obviously once you start getting into block grafts, you've got to take membranes out and you've got to take screws out as well. You can't generally place the implants at the same time. You've got secondary sites, cost to the patient, and then once you've finished, you then probably have to do a vestibuloplasty of Kazanjan to actually get the tissue back. And so then you've got two surgical sites, again, one in the palate and one down at the vestibule. So after all of that, the patient's going to be pretty battered. So I've been looking at this question for quite some time, and I was reading on a Friday evening in my exciting life, as I do, and I stumbled across this paper by Palmer Benfiti, and it looked very, very interesting. And it was a case series, and it was a dome device, and it was made, importantly, of just a normal suture material that you can buy from Ethicon. I mean, it's a bit specialist, but you can just buy it in the same way as you can buy Proline, the same manufacturer. And they were using old-fashioned graft materials, so they were using HA, and they were using allografts, I think, and they were using human bone, and so it was taking a year or more to get their results. And I thought, well, can we apply this to our protocol? So the suture that you use is 2O PDS, which is polydioxanone sutures, and they are a resorbable suture that's long lasting, and they don't actually resorb in the same way as a resorbable membrane or Vicryl does. They hydrogenate, which basically means that over time they just gradually dissolve, and they last for about 270 days. But importantly, for well over 6 weeks, they are strong enough to support themselves. And obviously with EthOss, our bone turnover time is 12 weeks till we get 50% resorption and osteoid formation. So that's important. And combined with my choice of material, which is synthetic B to CP, EthOss, with calcium sulfate. And the great thing is it's got particle size and consistency that is amenable to the use with this, which means that you can flow it in underneath the sutures. And it's like my bicycle. It's a talent compensator. So having a good suspension on your bike and having a good bone graft material keep you out of trouble. So, like Smarties, maybe this and EthOss is the answer, is what I thought. So EthOss and 2.0 PDS. So started experimenting, and then I saw a case going back to this one, and this is what really convinced me of the technique. This case was originally planned for a staged approach where we would place a couple of dental implants in the premolar areas, and this canine tooth was grade 3 mobile. It was wobbling around like nobody's business. It would move laterally a good 1.5 millimeters. Had no real bone support. So we were going to place 2 implants, allow them to heal, and then we were going to cantilever a temporary bridge in front, take the canine out, and then do the grafting in the canine, and then finish the case off with 3 implants separately. So you can see here that there was a little bit of an infrabony defect on the 3, which I decided to clean up just randomly with when we were doing the surgery. I did some RSD and filled these infrabony defects with the EthOss, and then we had quite a thin ridge, and I didn't want to expand it, so we decided to use we used a bit of ridge expansion. So I didn't want to split the ridge because it was a little bit fragile for that. So we expanded and placed the implants, and then we domed over the top, flowed the material in, and you can see this holding everything up. And then I placed some EthOss in the thing. I actually, with this case, I did put a little bit of hydroxyapatite in, mixed it up, just as a confidence thing, and then closed with Proline 5.0, and then 7 days post-op. This is what it looks like. No inflammation. Patient had no pain, no swelling. Didn't even take any painkillers. At this point, I'd just like to point out, you probably want to be using non-resorbable sutures, either Proline or some sort of PTFE. PTFE is a lot more comfortable for the patient, so that's what we tend to use these days. And then 3 months post-op, you can see this, and we've got quite a lot of tissue there. And you can see here you've got a nice gingival cuff, but above here, that's actually where the bone is. That's hard there. So we've had a massive volume gain. And you can see here, when we put the abutments on, that's the pre-op. And then this is the post-op, and there's no pocketing on this post-op, interestingly. And another follow-on thing is that my periodontist and I are using this a lot more for infrabony defects. And there's an adenum. I think there's a study going on where we're getting quite interesting results from using EthOss in periodontal defects. But notwithstanding that, you can see here, if you just measure the line across, what we've got. And this is one procedure, one time. No gingival, no special things with the gingiva, you know, no onlay grafts with palatal tissue, just pure, simple implantology. And then this is here, and so this is what we're doing to avoid the slump. So the question of whether to use membranes or not, in cases like that, you would always use a membrane previously, but with these materials, the material is actually so to membrane or not to membrane, that's the question. So that's the virtuous circle with these materials is no membrane means less volume requirement, because the material itself is the membrane, which means that you can explore a different approach. The tooth extraction and wait for soft tissue closure only. That's the 1 month Fairlab protocol. And then you actually get some free soft tissue within the socket, which helps you bulk things up. And then the reduction in need to split the periosteum afterwards. So all of this reduces your volume requirement. And then you've got to question what the actual membrane does. So what it stops is cellular transfer. It allows fluid ingress. It's mechanically stable, and it allows angiogenesis through. And the question is, can we do this without a separate membrane using these materials? And the important thing about EthOss is it is the membrane. So people say, well, where's your membrane? And the actual material itself is the membrane. It's the calcium sulfate in the material that acts as the membrane, and that's your semi-permeable membrane. And so a lot of people, when they're starting to use these materials, get quite nervous about it. But the periosteum itself is the thing that provides all of your nutrients, and so putting something in the way of that will slow everything down and cause problems with the graft and cause a lot of the graft to resorb, which means that if you don't use that, then you don't need as much bulk, which helps with these techniques where you're trying to gain quite a lot of extra bulk. I'm going to skip that. So another case is this one where we had a little bit of a defect here after the tooth was taken out. You can see. Now, if I allow this to heal fully, then I'm going to be in a lot of trouble. And really, you're looking at a plate to get this back. In my old life, I'd have to plate this really to get it back if we allowed it to heal fully. So with a big palatal defect as well, so you're looking at a choroid plate on the palatal and a choroid plate on the buccal, then leaving that for 6 months and then placing an implant later on. So I thought, why not apply this new technique to this site? So what we did is we waited a month after the tooth was removed. Frenectomy. It's quite important with EthOss whenever you're doing it, not just with these sorts of techniques, but with just any normal EthOss use. You have to look at your frenums, and the first thing that you do is look at your frenal pulls and just do a simple frenectomy. It doesn't need to be a Z-plasty. If it grows back after 3 months, it doesn't matter. You just want to just whip that off, just to allow the tissue to be stable for the 8 to 12 weeks you need it to be stable for. Then we raised the flap, and then we cleared all of this out, found we had a little hole. Everyone's going on about zero prep. So this was a zero prep implant because I could just lay the drill that I needed in. And in the end, I had to use a larger implant than I would. This is a 4.5 diameter, which is very rare for me to use in the anterior region. But I only really had the mid-third of the implant on the mesial and distal walls to actually engage. So we used an implant here, which is a DO implant with quite sharp threads, and we placed it, and it was just finger tight, really. It was stable. Before we placed the implant, we fully debrided all of the tissue out of the socket and placed a palatal graft to close that palatal defect, and we placed the implant. And then at this point, you can see here, what we did is we put the dome device in, which is where you have 2 little holes either side of the implant, and then you cut a little bit of the suture, and you place that in, and it acts like a dome tent effectively, and then you flow the material in underneath, and then it holds it. And this is 5 days post uncovering. And then you can see here what tissue we've got. And then this is fully healed. And then this is about 2 years follow-up, and you can see he smashed the crown because he grinds, and so it's functional, and it looks nice and healthy. And this is what the x-ray looks like. And so these are quite useful when you get ankylosis cases. So you take the tooth out and you really have to destroy the bone in order to get the tooth out, and then we're in big trouble. So what we did is we waited a month and opened the case up, and you can see that we've not got a lot of bone here. So what we did is, again, domed over the top, flowed the material in, made sure that it was nice and stable, and in this case we put the implant quite deep, and we put a healing abutment on, which again stabilizes the tissue, and then 4 months later we uncovered, and you can see actually here you've got floating little bits here, and this is on the x-ray around. It doesn't look as spectacular as it would on a bovine graft, but not to worry. You'll see this a lot with EthOss, and you'll think, oh, have I got bone? It doesn't look like bone. But what it is it's osteoid. For 3 or 4 months, it will look, when you uncover it, and feel like bone, but it won't be as radiopaque as it looks. And then over time, it'll just get better and better and better, because you can see over the top of the distal implant, the upper 4, it doesn't look like there's any bone, but then when we uncover it, it's hard bone, and I have to get a round burr out and go and find my disappeared implant, cut some bone away from it. So radiographic appearances can be a little bit deceiving, and this is what it looked like when we uncovered and allowed it to heal. And so with digital dentistry, we can have a little look and see and kind of guess where the bone is. And what we did is we did a model, and then I sectioned the model on the computer just to see what we had. We in the UK are very limited in terms of CT. We're not allowed to use CT in the way that other people are in the rest of the world. You know, in Australia, people take post-op CTs, I know, and in the UK, we could get into a lot of trouble for that. So we can't just take a post-op CT and see what it looks like. So we have to sort of guess in many ways. So here we can tell that we've got 5 mils of width at the abutment level, and so from that you can kind of conclude that there is something there, I think, and there is something in it. And so this is what it looked like beforehand, and this is what it looks like afterwards. And that's I think we did the crown on the 5 about a year and a half later, so this is probably a couple of years after the case, and it looks nice and stable. You know, it's not perfect. Obviously the papillas aren't back where they were, but I think for a single stage procedure that's quite adequate. So the other thing that we look at quite often is pontic site development. And so when you're not actually placing the implant in that particular site, you can actually develop a pontic site. So this is a case where I wasn't overly happy with the pontic site after the case, because I was happy with the canine where I put the implant, but the pontic wasn't great. So and here you can see where the canine implant was placed, but the lateral and the central were pontic sites, one off the central and one off the implant that I placed, and they just weren't developed as nicely as I would like. So when this came up again, what I thought is we could do a dome device actually in the pontic site, even if you've got adequate bone where you're placing your implant, just to give you that extra little bit. And this is what it looked like afterwards. And you can see that actually we've got a good contrast of an old implant with this pontic site here, not developed, and then under the existing bridge, the pontic site where we put the implant in is nicely developed. And then this is a durable temporary case where quite often you have patients who don't have the finances to do full-on implant work, but need something doing. You can see here, this is quite a strange case where one half of the mouth was perfectly stable and the other half, the right-hand side, was just a real problem. So a lot of people would say, well, let's sacrifice the lot and do an all-on-4 here. What we did is we did a half-on-4 welded, and we decided to place an implant in the lower central region. As you can see, it's a little bit compromised in terms of the bone. So this was an immediate placement case because she refused to be without her fixed teeth. So we can see here, and you can see that when we place the dental implants, these are ankylosed implants, and you can see we slit this one down the side of the central incisor, and there's not a lot of bone there. And we placed conometric abutments, and then we placed our graft material. This was a welding case, so we did intraoral welding, and then we built our bridge work up and placed the bridge, and that was immediately functionally loaded on the day. And so you can see here what it looks like afterwards, and we've got quite adequate tissue response around there. And so this is a 6-month review, and where I did not place a dome device and left the bone in situ, we've had a bit of recession. I've added a little bit of composite to the bridge, and this actually is, I think that's 3 or 4 years later, with the same temporary bridge in. I've added a little bit of composite to the bridge, and it all looks fine. I've lost that final picture, but that's stable still. I saw the patient about 3 months ago, and everything's absolutely fine. The durable temporary is still in place, and she doesn't want a final ceramic restoration because it's all fine. And that's a very cost-effective treatment and very stable. So then we're pushing things a little bit. Sometimes these cases where you've got a lingual shelf can be treated a little bit differently, and this was a bit of a challenging case to get an implant in situ, and this is, sorry, yeah, that's moving. So as you can see, this is a very strange anatomy, and with an implant in place, you can see that there's really no way of doing this without significant grafting if we do it in a conventional manner. So what we did is we treated this like a sinus graft in many ways. So lingually, we raised the tissue, and this is one of the few places where I'd actually place a membrane, and we did an oblique hole, and we placed a membrane just to contain the material and stop it from migrating, not any other reason, and placed the material in the lingual, and then placed the dental implant, and you can see here there's a real shelf. And so what we did is where's this picture? Oh, we placed the dome device and placed some EthOss in there, allowed it to harden, and then this is what it looked like after we uncovered it. This is all bone. The implant had been covered over with bone, and I'd actually had to scrape bone away from the head of the implant to expose it. And then this is a case that we did, and we submitted to the EDI journal, the European journal, and this is the upper central incisor, which was left in situ due to the patient's refusal to extract the tooth. Again, frenectomy, and significant bone loss once we took the tooth out. And then there's a really large infrabony defect, and the lateral incisor is not, doesn't look as if it's long for this world. So what we decided to do is combine techniques. So in this one, we de-epithelialized around the lateral for a coronally repositioned flap. It's not necessarily to gain any, but it's to stop recession. In this case, we did the flap, did the implant placement, and then debrided the tooth and surgically treated the lateral incisor with a modified MIST technique. And then we did the dome device on both the central and the lateral incisor, palatally filled with EthOss, placed the dental implant, and then closed up tension-free. And this is what it looked like straight afterwards. And this is after uncovery. And then this is, I think this is 12 months later, with very nice, adequate result and complete stability of the lateral incisor, no pocketing or probing, and the central looks fairly reasonable too. So going on to technique. So forgive the poor photography on this one. So this is raising the flap. These burrs are called degranulation burrs. I don't know whether EthOss sell them in Australia, but they're very, very useful for getting rid of any granulation tissue. And then just placing the implant. And then this is a Stevilock pin drill, which you use just to do the holes. Again, just mini osteotomies, and then more degranulation. So I always hand instrument first, then degranulation burrs, then do what I need to do, and then degranulate again and just check, because there's always extra things. And this is the difference between success and failure with EthOss, is how clean is your bone, how pristine is the bone. You can see the dehiscence there. So these cut to length, the 2.0 PDS and placed. Does take a little bit of time to get it in situ. And then you can actually push on it, and it's very, very stable, like pressing on the top of a dome tent. This is a near-dent drive implant, so it's an expansion type implant. And then we use a wet mix initially, much wetter than you would normally. And you flow it up underneath, and then dry as you go, and compress and dry, compress and dry. And then over the top. Again, you might note that I've got a 2mm cover screw on the implant. This is a cone Morse implant, similar to EthOss. And again, that acts as a tenting device. And that's the technique, tension-free closure. Suturing is quite important with this. You really want to pull the flap up with your lateral sutures, and then actually on the crestal incision, that needs to be totally tension-free. If you need to do periosteal relief, do it at the start of the procedure. So in conclusion, the dome is still in its early stages. It looks pretty promising. We've got reasonable long-term results, which work very nicely. The question you always say is, would you get these results without tenting? In some cases, maybe. In other cases, I think you'd struggle. It's cheap, it's reproducible, and it's minimally interventional. The question is, can we get vertical augmentation? Not so sure. We've done a few in the posterior mandible, like that case where with the lingual shelf, which have worked out really nicely. And currently trying to get a little bit of research funding to look at new products as well. So and that's it for today. Thank you very much, and yeah, welcome any questions.
Okay, just out of curiosity, do you have any more videos of different areas for tenting to show?
No, because I don't have the my video camera is it broke and on the microscope, and so it's quite difficult to get the camera in. So I am getting a new microscope, a CJ Optic, which is optimized for video, and so I'm gonna be doing more as time goes by. But it's just I haven't got any videos. They're a bit difficult to capture, actually. So that's why
I guess if you, when you do some more, if you could kindly send them through, and then I can send them on to who is actually attended this evening.
Yeah, absolutely.
I do have a question here. Is there any literature that supports the intact periosteum also acts like a membrane?
Oh yeah. There's more literature on that than anything else, because it's straight out of the orthopedic literature. If you showed an orthopedic surgeon bovine bone, they'd wonder what the hell you were doing. It's the calcium sulfate itself stabilizes and prevents ingress of the tissue, and you've got to remember that the reason why there's a misapprehension as to actually what the mechanism of action is around bovine and high hydroxyapatite materials. People think that they close the periosteum over the top, and what happens is you get cellular epithelial ingrowth through the periosteum into your graft material. That's not what happens. What you get is a massive inflammatory response, and then you get the progenitors going from the periosteum into the material and causing it to have epithelial cells inside it. When you do a graft with a synthetic, the barrier is within the material because it's a lot smaller particle sizes, and it sets as well. So the calcium sulfate microscopically sets, and then it allows neoangiogenesis in a controlled fashion, because the calcium sulfate goes within 2, 3, 4 weeks. That's gone, and that's about 20% of the mix, leaving the beta tricalcium phosphate in situ. Importantly, the beta tricalcium sulfate is a very small particle size, so it's very closely interlinked, and you don't get the inflammatory response. So it's slightly more complicated than just allowing membranes in, but there is literature. There's a lot of literature on that, and
where would they find that literature, like the best sort of the best ones to look?
Well, we can we can get that over, I think. I'm pretty sure.
That'd be fantastic, and then I can pass it on to them. That'd be wonderful.
Peter actually, Fairbairn's got a whole library on that.
Oh, fantastic! Well, I'll get in contact with him for these attendees, and I'll get that to them.
Yeah.
Another question. What size or color of the stab lock drill did you use for the tenting suture?
Green,
Green.
fresh green ones is the best, I think.
Lovely. And then I will give you, I think I've got one more. Do you leave the dome device in situ?
Yeah,
Is it
that's the whole point. Yeah, it just stays within the graft material. So it's completely within the graft material, and it just gets
does it
bioabsorbed.
dissolve? Yeah, okay.
Yeah, it takes 270 days to go completely.
Okay,
So it's long.
fantastic. Excellent. Okay, well, that's some of the questions that we've got this evening. There's a couple more that I'll have to send over to you.
Yeah.
But thank you so much for that. And I will, like I said, for all the attendees on this evening, I will get that information over to you guys once we have it. And this evening is recorded, so once it is edited, you can go back on that and review it again if you need to. So thank you all very much, and we will look forward to the next one. Thank you so much, Mike. That was wonderful.
Thanks a lot. Thank you very much.
Thank
Have a good
you.
day.
You too.
Cheers.
Bye.
Bye-bye. Bye-bye.